afternoon, and welcome to another fine epilepsy course talk from the very eloquent Elinor Ben Menachem, who is based in Göteborg University, Sweden, and she spends a lot of her time also in the US. She's been on the AES committees, several of them over the years, and she will be talking on withdrawal of antiepileptic drugs or anti-seizure medications in seizure-free patients. Who should continue and who should stop, and how can you help your patients? And I'm very happy that we have Dr. Manjari Tripathi from AIMS. Everybody knows her as the co-host, and she will be also taking questions and making a few comments during this talk. So Elinor, thank you very much for being here with us. We're waiting to listen to what you have to tell us. You always have new data on this.
Yeah, well, yes, this is new. You haven't seen this. I don't know. Maybe you have, but I don't think all of the 320 participants have seen this. So thank you very much for letting me talk and to tell you about something that I think is very important and that I use daily, the tools that you will learn about and how to use them is something that I use almost every day in my clinical practice. So I think this will really have meaning for you after you listen to my lecture. But first we will talk about the background. However, think about this, please. What if a patient is seizure-free for 2 years? Would you try to stop his medication? Write this down for yourself, because at the end, then you can see if you changed your mind. Do you stop or reduce medication for every type of epilepsy if the patient is seizure-free for 5 years? Think about that question too. The next question is, imagine if you are a 30-year-old with an EEG verified right temporal lobe epilepsy. So you know that. Onset was the age of 25. The cause is unknown and you have a normal MRI. So you're thinking about yourself. You have been seizure-free for 4 years with only one anti-epileptic drug or anti-seizure medication, but we're going to say anti-epileptic drug or AED for this talk. You work, you just got married, you drive a car, you want to build a family, and you have no side effects of your drug. So you're just feeling fine. Would you be willing to discontinue medication if your doctor said, well, maybe we should start reducing your drug? So think about that. The next one is you're treating a young girl and she's 18 years old. And she has JME, but she's been seizure-free for 3 years with levetiracetam. She was 15 years old when she became seizure-free, but really she had some type of feelings, maybe myoclonias, even before she became seizure-free. And she has not told her husband that she has epilepsy. Would you stop her AEDs before getting married? Okay, so now we can continue. So there are both pros and there's cons about stopping or continuing anti-epileptic drugs. Of course, if you stop, you have the risk of having more seizures. And if you have a seizure, you can injure yourself. And if you have a generalized tonic-clonic seizure, there is always that risk of a SUDEP. And you just heard about that yesterday. There is a consequences of reoccurrence if you should get a seizure. It's not always sure you're going to be seizure-free again if you have a reoccurrence. And then you're afraid to have a seizure in an awkward situation at the workplace or other places, social life, and then the cultural consequences. But the disadvantages of continuing are that you're taking these drugs and you don't know, would you be seizure-free if you're still taking these drugs, and you have to pay for them and they have side effects, and there's a teratogenicity problem and there's drug interactions. And it's a burden of always remembering to take your drug. You may not forget it, or you can even get seizures because you forget to take your drug. So one of the most important still stands today from 1999. We're talking about 20 years ago, but this is anyway the only real large randomized trial. And here, this was David Chadwick, a colleague of ours who is no longer active in our field. And he did a huge study in Liverpool with 113 patients, and they were seizure-free for at least 2 years after being diagnosed with epilepsy. And 83% were on monotherapy, mainly low dose. And they had this study in all of England, so there's 125 clinicians from 45 centers. And these patients were randomized either to gradually withdraw their drug every 6 months, or they should continue their medication. And the median time of follow-up was 5 years. So if you look at what happened, the patients, and we don't know what type of epilepsy, we're just calling this epilepsy. We'll see later on more about the different types. But if the AEDs were stopped, there was a 48% chance that the patients would get their seizures back again. And if the drug continued, there was actually 33% chance that they would get a seizure again, in spite of the fact that they were on that drug. So it's a problem there. Now, 409 of these patients who were seizure-free after the first seizure, they were previously randomized, like all the others, to be withdrawn or remain on the anti-epileptic drug. And here we're looking at the different types of drugs. 237 were on carbamazepine, some were on phenobarbital, 72 on primidone, 184 patients on phenytoin or valproate. And here you see what happens with valproate or phenytoin or phenobarbital. You see that the ones who were still on had a better chance of remaining seizure-free than when these drugs were taken off. So just taking off these drugs makes a difference. Only with carbamazepine, you can see that it didn't matter if you were on it or off it, it was the same. So I think what we can learn by this chart is that phenytoin and valproate and phenobarbital, you have to be even more careful about reducing the drug than if they're on carbamazepine. But if you look in this study that we're talking about, the patients with generalized tonic-clonic seizures that were immediately controlled by the anti-epileptic drugs and were seizure-free for 4 years, and they were feeling fine. So the ones who continued after the 4 years, after 1 year, 7% had seizures, and after 2 years, 14%. If, however, you withdrew the drug after 4 years of being seizure-free, after 1 year, there was a recurrence of 21%, and after 2 years, you could expect, as this big group as a whole, 28% would have a seizure reoccurrence. And you may think, well, that's not so bad, 28%. But if you drive a car and you work, those people in this 28% are very badly affected. So you have to think about the individual person and not just statistics. In adults with generalized seizures, myoclonus, so in an abnormal EEG, in other words, maybe they had JME or other idiopathic epilepsies, then continuing the AEDs, 44% after 1 year had seizures, and after 2 years, 69%. However, if you tried to take off the drug with these patients with abnormal EEGs, there was an 84% chance of reoccurrence after 1 year, and after 2 years, a whole 92%. So this group, anyway, we know should probably continue the drugs, although continuing drugs, they still had reoccurrences. Now, we don't know if these reoccurrences occurred because they forgot to take the medication or they were on the wrong drug for that seizure type. That could very well be as well. We don't know that. What about children? Well, these are also old studies by Ann Berg and Shlomo Shinar, 1994, where they looked at 25 studies, and they found the risk of having recurrence when you take away the drug in an adolescent onset is higher than if it began in childhood. And if you have remote symptomatic or focal onset epilepsy versus the idiopathic abnormal AEDs, you have a higher risk of reoccurrence. So here there were 97 children seizure-free for 1 year. See, the whole problem with this narrative is that they don't specify what type of seizures these children had, but taken as a group, they withdraw, and then 61% were seizure-free for 24 months. And that's very good. But what about the other 39%? And in an adult population that I see the 39% who the pediatrician takes away the drug, they're seizure-free for 2-3 years, come over to the adult clinic, starting to drive a car, and then bang, they get seizures again. So these are all factors that we have to take into account, and there are tools to help us, and I will show you at the end of this talk. Now, all AEDs have potential side effects, and of course, every pediatrician wants to take away the drugs. I mean, they don't want their kids going into adolescence and adulthood with these AEDs if they can help it. Because AEDs, especially depending on which ones, but especially the enzyme-inducing or inhibiting drugs, cause osteoporosis, hormonal disruptions, teratogenicity that we've all heard about, infertility, libido, reduced libido. And then you have the drug-drug interactions, and these become very important if you have comorbidities. And most of our patients, or many of our patients, maybe 60-70%, have significant comorbidities when we treat them and they're taking other medications. Then you can get hypersensitivity reactions, especially to carbamazepine, as we've all seen, thrombocytopenia and pancreatitis, hypothyroidism, hyponatremia with many of our drugs, and many of the drugs that patients are taking anyway for depression. So you put the anti-epileptic drug and the antidepressant drug together, and you can get hyponatremia. So we have to think about that. And weight gains and visual field changes like with vigabatrin. Then that's not the worst of the problem, because many of our new drugs are pretty good and they don't have any enzyme-inducing properties, but they can give cognitive slowing, depression, which is a big problem with certain drugs like levetiracetam, and other psychiatric problems, suicide and suicide ideation. And then the dizziness, ataxia, headache, tremor, insomnia, we all know about these. And it costs a lot of money, and people feel that they're taking a drug. They're always reminded that they are not truly healthy. So in Akershus, which is in Oslo, they did a randomized double-blind study, and this was pretty good because it was double-blind as well, to assess the effects of withdrawal on cognitive function, seizure, relapse, quality of life, and EEG. So they included 160 seizure-free patients who were on monotherapy for 2 years and we don't know what type of seizures they had. And they looked at the relapse rate, or up to 12 months. And so they divided these patients to withdrawal and non-withdrawal. So that in the seizure relapse, 15% in the withdrawal group had recurrence of seizures, and 7% in the non-withdrawal group. Now, after withdrawal, 27% of those relapsed after 3.5 years. So even though after a year they said, oh, but only 7%, after 3 years it was 27% who relapsed, and these patients were on monotherapy and had mild epilepsy. However, doing the neuropsychological tests, many patients felt that they were better, and there was an increase from 11% of the patients up to the who had normal results up to 28%. So there's no doubt that our anti-epileptic drugs are not placebos. They do have significant effects for epilepsy and for the neuropsychological functioning of our patients. So that's another reason why maybe it's good to reduce the drug. And then there was no change, however, in the patient's feelings of quality of life, or EEG. Now in Yonsei University, and this is in Korea, they looked at the time to relapse after being seizure-free for 4 years, and they divided in early relapse and late relapse. And in this group of 336 patients, 64% experienced relapse. So that's like the largest group so far. But they followed them for a long time. And the longer they found, the longer the symptom duration, that if a person had had epilepsy for over 5 or 10 years before they became seizure-free, that was the strongest negative predictive factor. So if you have a patient who you've worked with a long time, finally you get them seizure-free after 10 or 20 years, it's not a good idea to say, oh, now you're seizure-free, now let's reduce the drugs, because you have a 4.7-fold risk that they will get their seizures back again, and you may never be able to get them seizure-free again. Now, a younger age of below 20, was also a negative factor, as well as focal onset or localization-related epilepsy. And here is a study, also a newer study done in China, in West China, with seizure-free patients. And then the patients were seizure-free for at least 2 years, and then they dropped their drug. And they found the probability of reoccurrence was 16% for 12 months and 20% for longer period of time. And so the most important things they found was long AED response time in multiple seizure types. So here's also a little clue. If it took a long time, just like in the Korean study, to finally become seizure-free, that was a negative factor, and if patients have other seizure types. So here is the AED response time. So the green shows that if they had a short response, in other words, that they responded to the drug in less than a year, then you had a better chance of becoming seizure-free than if you had to work a long time with the patient and try different drugs before finally becoming seizure-free. Here, if you look at the multiple seizure types, so patient says, I just have generalized tonic-clonic seizures, or I only have focal onset seizures, then the chance of becoming seizure-free was better than if the patient had both, or if they had multiple seizure types. It's also a warning sign, should come into your head that this can be less successful by reducing their drugs than if they have only one seizure type. So who should continue these drugs? Well, we have follow-up studies stretching over 40 years to help us understand this. And we do know that certain childhood epileptic syndromes like Rolandic epilepsy, child absences, Panagiotopola syndrome, they have a good chance of becoming seizure-free if you withdraw their AEDs. But then you have all of these risk factors that we're going to go into in this algorithm. And that is, how long did the patient have epilepsy before finally coming seizure-free? What is the seizure-free interval? Is it 5 years, 10 years, 20 years? Because from each year, the risk of getting a seizure onset improves. How old was the person? Are there history of febrile seizures, which is a negative, or the number of seizures before remission, and the absence of a self-limiting syndrome, in other words, the Rolandic spike and absence and the Papadopoulos syndrome. What about developmental delay? That's a negative aspect. Or the epilepsy, if you have an abnormal EEG before withdrawal, you should stop and consider this more carefully. Women are more prone to seizure reoccurrence than men. Family history is important, and so are focal seizures. So this is what I want to mainly focus on, and this is from Lamberick, and it's in the Lancet Neurology. And if you're interested, you can read the article. And they looked at a systematic review and a data meta-analysis and came up with some algorithms that we will be able to use for our patients. And we're not going to go through all of these, just to see that there were a lot of records, like 2,588, but at the end, there were only 10 studies of only 1,771 patients who they used in their calculation. And what they did here, and you can see, we'll go through this, they gave points. What is the risk of having recurrence of seizures? From 0, that would be the best, all the way over to 20. So they gave numbers for this. And so epilepsy duration and before remission, you see that if there was a 40 years of epilepsy and you became seizure-free, I actually have one patient like that, then you get a higher number than if you only had 1 year before remission. And the seizure-free interval before withdrawal, well, if you had 24 years of being seizure-free, well, that's a very good number. But if you only had 5 years of seizure freedom, you get actually a very high point of 18. So this idea of withdrawing after 5 years is something that we really have to reconsider. And many who are in the field of epilepsy know about the 5 years, but many neurologists who are not working solely with epilepsy do not know that you still have a pretty big risk after 5 years, and you just can't withdraw the drugs for everybody. And I find this when I'm at another hospital and I'm consulting and helping, I see that many of the doctors are saying, well, the patient's been seizure-free for 5 years, we have to start reducing the drug. And I want you guys now to stop and think that maybe this isn't always a successful idea. It depends solely on the patient, what type of seizure they have. The age of onset is important, and the older the age, the more risk of getting recurrence of seizures. History of febrile seizures, number of seizures before remission. Under 9, you're in a better position than having 10 or more seizures. Self-limiting epilepsy is very positive. If it's not, you got to think about it with the focal onset seizures. They're not self-limiting epilepsy syndromes, neither is JME. Developmental delay, if you have it, there is a risk there. And if you have an abnormal EEG, you have a risk. So if we go on, then, and you can go into this, if you see the online prediction tools, go in, use it, put it on your favorites, and I use this continually with my patients. And they have 3 types. The first one is antiepileptic drug withdrawal after pediatric epilepsy surgery. So you have a child who was operated on at the age of 5, he's seizure-free at the age of 10. Maybe he doesn't need that drug. And that is very possible. It depends on many factors, but also where it is in the MRI and the EEG. So that's very important for pediatricians. Then you have the general AED withdrawal risk calculator that I use almost every day because my patients come to me and they say, I've had this drug for so long. I want to stop. I don't need it. And I say, well, wait. And I say, take your chair and come by me, which we can't do now on the corona times. And then we look at this risk calculator together and we fill it in together. And then they understand what risk they might have if they take away their drug. And then a recent one is a first consultation for a child. A child has 1 or more potential seizures. What is the risk of the diagnosis of epilepsy? And this is very good for the pediatricians, and one should use this. It gives you a security because it's based on all of the published literature that we know, at least today. So here, this is a picture of there is now the 3rd one also, but here you go into AED with risk calculator and you just click on that. I don't have internet access here to be able to show you how it works in practice, but you can go on example, age at withdrawal, 12 years. And time to withdrawal, this is for the epilepsy surgery. So this is just to give you an example. So a child, age at withdrawal of the anti-epileptic drugs is 12 years. That's a usual time. Time from withdrawal from surgery is 5 years. So the child was 7 years when it was operated on. The MRIV showed just a focal, not multifocal dysplasia. And the completement of the resection was complete. Seizure frequency before resection was, many. And the number of AEDs at the time of surgery withdrawal was 2. And the EEG now after epilepsy surgery was normal. And there, if you put it in this algorithm, which I just gave you, then you see 2-year seizure reoccurrence is only 3%, and 5 years is 8%. And a 6-year chance of being seizure-free is over 98%. So of course, you would want to take away the drug on that child. However, if the EEG is abnormal and you have a multifocal abnormality on the MRI and the resection was not clean, then okay, after 2 years, you get a 28%. But by the time you're at 5 years, you have 56% risk. However, if you keep going for 6 years, then you have a 90% chance that that person will be seizure-free. So this is more of a dilemma than if the child just had one focus gone and the person is seizure-free. Now, this is what it looks like. And so we're going to talk about, so here is an example where the duration of epilepsy before remission was 30 years. In other words, it took a long time. I have many of those patients. The time since the last seizure is 3 years, because we have new drugs. And with the new drugs, we have better possibilities. And so I have patients, many who have suffered for so many years, finally become seizure-free. But now they're seizure-free for 3 years with 2 drugs. They're 19 when they have the first seizure. A woman, family history, no family history, no history of febrile seizures. I see so few patients who have a history of febrile seizures, actually, but had at least 10 or many more seizures than that, and normal intelligence, focal seizures, EEG abnormality, wasn't totally free, and then you see it. If you would dare to reduce this drug after somebody's been had seizures for 30 years, then you will have a 90% chance that the seizures will come back again. So if a patient has had a long time of epilepsy, don't try to reduce their drugs. So why discontinue even if the odds are not so good? Well, patients want to try. They have an interest of living without medications. They really hate the drugs. They can have toxic side effects, and they think that they will be healthier without the drug than with the drug. And we have to respect what the patient thinks, but we can educate them. We can educate them with that many of our newer drugs are not toxic in the long term, and they will not be sicker if they continue their drug, on the contrary. And then, of course, we get to this teratogenicity, and that is always a problem. Should the patient continue or should they not? And we know today that levetiracetam is a good drug for, not increasing teratogenicity, and lamotrigine and carbamazepine and oxcarbazepine are pretty good as well. So we know more because of the registry studies that have been done. So we're a little bit better on that. Do the newer drugs have lower risks of teratogenicity? We really don't know. And so we can't really for sure say much about the newer drugs. So there was one survey, this was back then in 1996, where they asked patients, would they take the risk of relapse to see if they could withdraw the drug from the child, and 20% said they don't care if they get a relapse, they wanted to try it. Now, with this study from David Chadwick, the MRC study, relapse increased distress, but only 8% of the people who relapsed regretted their decision. So the ones who did not relapse, they were very favorable and they felt better and they were happy when they were not on drugs. So you have to decide what the medical, social, emotional implications are. And you can say basically with a trial, a child remaining seizure-free and you take away the drug is between 61 and 91%. And the cumulative probability of an adult remaining seizure-free, irrespective of what type of seizure they have, is between 35 and 57%. But there's a whole 50 or 60% who will be relapsed, and it can be devastating if they're in a car. So should we withdraw this? Well, you have the prediction. You can use those prediction tools. And you can see that it is a reasonable consideration for a select group of patients. But we have to think about these risk factors so that our patients don't end up getting into serious trouble, especially if they're on drugs which are not dangerous to take, which have no consequence for people's health. So again, if you're 30-year-old and you have this onset at the age of 25, you don't know why, and you just got a great job and you have no side effects, you have really good AEDs, would you be willing to continue the medication now? And so you can think, did you change your mind? Here, if we put in our prediction tool with our patient, with what I just told you, the 2-year recurrence is actually a whole 60%. And 5-year reoccurrence is actually 73%. Now, what about our patient with JME? Would you stop her AEDs before getting married? So think about it. And here's the answer. Her 2-year recurrence rate is 68%. And after 5 years, she has an 80% chance that she will get her seizures back again. Is it worth it? Is it worth it to take these risks right at the beginning of your life when everything counts? You have to think about it together with the patient, but the patient should be with you on deciding if they are willing to take that risk or not. What you can ask a patient is, okay, you want to reduce your drugs. Let's go in and see what the probability of you having a seizure is. What risk are you willing to take? If you ask the patient, what is the risk that you would take, many would say 5% or 6%. Very few would say 68%. So in conclusion, withdrawal can be attempted in children when the risk factors are favorable, and please look at those. And this can improve significantly school achievement, social behavior and development, and sexual development. So it can be important. And you should attempt in adults only if the risk factors are favorable. And please go into that calculation withdrawal tool and make sure that you're in the right area to advise your patient that they can stop. So that is my presentation, and I hope you learned something, and I hope you will use that prediction tool. It's really great because then you and the patient are on the same wavelength, and you are working together as a team and not you as a doctor just dictating, and the patient goes out and says, I don't believe that. So if they're together with you, they understand it better. Thank you.
Thank you, Elinor, and thank you for giving us a very good direction in using, seizure prediction, use of tools. The Lambrink study was very good. Many of us probably, have to look at these things and start using in our practice. So it was very practical for us. Manjari, would you like to comment and then take questions?
Yeah. So, in particularly in India, there seems to be a paradox. Particularly, the problem is when we have these young girls who have epilepsy, and there is a notion which is there, which still prevails among many physicians, that there is something called as a course for epilepsy. So when they're seizure-free for 2 or more years, the parents are very anxious to kind of taper the drugs, particularly if the girl has to go in for a marriage. And if we sit down with the stool and we explain to them, they may understand. But then this becomes a very often a reason for parents to do doctor shopping, because they will go to a doctor who tells, okay, 2 years seizure-free, now we can stop, even though on a prediction tool, the risk may have been very high. So that is something cultural which we face. They want to hear from us that the medication can be tapered and stopped, particularly when the question is a young girl who's about to get married in the next 2 or 3 years. The second is we had done a study on tapering, and it was published in 2019 in ACTA, where we had 408 patients. And a significant number of patients who had a history of prior failed tapering relapsed when subsequent tapering was attempted. So I think this should be a red flag. If there's a history of prior failed tapering, then these are more likely to relapse. The other category which relapsed was those who were consuming a lot of alcohol and smoking. So wherever lifestyle issues are not regimented, maybe this category of patients also relapse more. So apart from that, in our study, we had the same, the longer duration of epilepsy, the more number of seizures, multiple seizure types, which predicted relapse. So yes, it's easy for us. We do try to build a dialogue between the patient and ourselves, but very often our patients culturally want this course to be finished and the medicines to be tapered and stopped.
Yeah, I mean, I agree with you. And that's why this looking at the algorithm, because it's not an emotional message. It's just the patient. I say, how long have you had epilepsy? And I put it in. How many drugs do you have? And I put it in. And how long have you been seizure free? So the patient gives me the answers as I'm going through the algorithm. And I say, okay, shall we look at this? And then they're part of the decision process. And that makes it much easier. But I mean, of course, they would like to put on blinders and not see what's really happening. But the fact is, if they jeopardize their children if you want to take away the drug. Because, just when they're going to get married at the marriage ceremony, then this poor girl can have a seizure too. Everything's ruined, right? So, people have to think about this. And many of our drugs, like levetiracetam, are not dangerous. And I would think it would be better to not tell the husband and just take the drug. Because who cares? It's much better to be safe than sorry. Because having a seizure can really ruin a marriage too. The husband can say, or the wife, you didn't tell me you had seizures. You've been lying to me. And you can break up a whole marriage and families that way too. Right? Am I correct?
A little contrary to the way to your presentation, contrary view to your presentation is that often we have patients who have been seen by a neurologist or other physician somewhere who have been started on anti-epileptic drugs, and they come to you and they say, "Shall I stop the medication?" What do you tell them? Do you revisit the diagnosis and rule out non-epileptic attacks at this time, or do you just would you do a repeat EEG before withdrawing if the person has been seizure-free, as you said in your talk? Because there's a question from somebody who is an elderly gentleman. He's had 9 episodes of syncope. He's had 2 right focal seizures, and he's had a 3:1 block on Holter monitoring. He's got a double chamber pacemaker. He's on 3 anti-epileptic drugs, and he's had his last so-called seizure 2 months back. So he's asking, can I withdraw my medications at any time, or do I continue? So this is the...
Yeah, well, 3 medications is an awful lot. So maybe one could at least reduce, and that is a good idea, to maybe take away the drug load so that it depends on what drugs the patient has and can you reduce them. And of course, if they're on phenobarbital, it may be a tough thing to really stop the drug because of abstinence seizures. But there are many of these drugs that you can slowly taper off. But if he really had real seizures and he's so old, then the risk of having them back again is pretty big. And so maybe he can be on 2 drugs, but 3 sounds like a little bit over the top anyway. That's what I would do. I would just slowly start reducing 1 drug at least. But I would be afraid to take away the last one anyway.
Manjari? Any questions from Manjari?
No, I guess maybe we should take the questions from the participants.
Yes.
There are 50 questions.
Yes. Should we give anti-epileptic drug for unprovoked single episode of seizure in life with normal brain imaging?
Well, and what about the EEG? And what about the consequences? So this is always a problem. And the ILAE has a new diagnosis criteria that if you feel that the risk of having a seizure is high, like 60%, then you should treat from the first seizure. However, if you have a normal EEG, you have a normal MRI, and you could see that the patient is, they were up all night and they were drinking or whatever it is, then I would not give an anti-epileptic drug. If there was just absolutely no reason why this person had a seizure, that would be more controversy, and maybe I would send them through. It depends on their age as well. Because if it's an older person, I would send them to a new MRI, a 3 Tesla with epilepsy protocols and looking at the brain in other ways than just a regular 1.5 Tesla MRI. But so it's age related, it's situation related if you treat the first drug. What do you think? I mean, you do this as well. Dr. Yardy, what do you do?
Yeah, that's what we do. Yeah, we look at multiple factors. We just don't look at one thing and do it. So even a patient comes with a single seizure, we try to work him up, look at family history, age of onset, the factors that you told. I don't want to repeat them, and then make our decision. And if we feel that there is, and of course in the pediatric age group, we see whether they fit into certain syndromes that have a certain natural history. Or if it's a JME, we know that they're going to be seizures.
Well, then you have to,
You have to.
Yeah, it depends on the age. A 15-year-old is much more likely to have it again.
Right.
Than, but what about the 80-year-old? Well, he's more likely to have it again too, because it must mean that he has some cerebrovascular disorder, something wrong. Maybe even, which I've seen with old people, just these small white spots, these cardiovascular changes that are subtle, but still people have seizures from these. Now, I would probably treat an older one after the first seizure with a drug. Teenager, I would probably treat. It's very difficult. You have to know the whole circumstances. You have to put it in an algorithm. Yeah.
So there is some question about related to the Indian scenario. If you have a patient who has seizures, neurocystic cirrhosis or tuberculous involvement, and sometimes post-stroke seizures, how long do you continue, and would you ever, what is the time when you would withdraw them, or would you withdraw them at all, especially post-stroke?
Yeah, you have a brain damage. You have that lesion, and that lesion will not disappear. It's there. For tuberous sclerosis, I don't think we ever cure our patients. And for cysticercosis, I doubt if you're really ever going to, cure that patient. With a stroke, you have that lesion sitting there. And I think that the risk is very big if you withdraw the drugs. Now, with a stroke, if you have an immediate stroke, you have immediate seizure with the event, then the risk of having epilepsy is not as great as if you have a seizure a few weeks after the stroke. So it depends on when the seizure occurred and how big the lesion is and where it is. So it's also situation related. There is no pure recipe for each thing. But tuberous sclerosis, I can't imagine taking away the anti-epileptic drugs there. Please, you guys, you experts, also chime in if you think that I'm not following your pattern of thinking.
Manjari,
yeah. So for neurocysticercosis, the data says that when you have neurocysticercosis, it undergoes various stages of degeneration. So from the cystic stage, it goes to the colloidal stage, to the granular stage, and then the calcific stage. So by the end of 12 months of its detection and producing seizures, about 75 to 80% of the cysts have reduced in size and calcified. By 18 months to 2 years, the rest would calcify. It is known that we give treatment as per our guidelines for about 1.5 to 2 years, and then we do taper the medicine, and about 15 to 25% of them will recur, and a minuscule 3 to 5% will have, drug-resistant epilepsy with neurocystic psychosis. So we do taper the medicines because many of them may not recur, particularly if we've told them to follow a regimented lifestyle. And if they recur and when they recur, we do restart. And these would be those patients who have a remnant calcification and perilesional gliosis, which can be picked up by the empty sequence in the MRI. So these are the high-risk patients where there is a perilesional gliosis and there is a residual calcification. That recurrence of seizures may happen in these patients. But the clinical practice in India is that we, as well as our recommendations by the Indian Epilepsy Society, that we do taper after informing the patient and the patient's caregiver of the chance of recurrence.
Yeah, so I don't think that Limerick's algorithm really was thinking about cystosarcosis, because this is something that we really don't see in Europe or in America, probably more in the southern states. But I mean, like in Sweden so far, I think I have seen 1 or 2 patients in my career. So this is not such a problem that it is in India. So it's good that you have guidelines about the course of cystosarcosis. It would seem to me that depending on where the lesions are, that they can be more epileptic or not. So this is also a consideration.
So withdrawing is
other
not
question?
very easy. No, withdrawing is not very easy, especially because of this difficult mix of symptomatic epilepsy, brain damage, and so many other factors. So there's no single dictum. That's what we learned from today's talk. That there is.
Yeah.
Initially, we were taught as students, and that there's a rule of thumb that there's a 2-year seizure freedom. You can get rid of drugs, and you have 84% people will go off, and 20 may relapse, especially in the first year of withdrawal. Or some other studies, the older studies said 4 or 5 years, but I don't think that really holds today, as and that's why your talk is so important to all of us. Somebody asked a question, that you said that the importance of EEG at the time of withdrawal. We do that, and we withdraw the drugs. Post withdrawal, is there a role for EEG again, even if the patient does not have a seizure?
If a patient feels fine and they don't have a seizure, maybe in certain types like JME, there might be instances where you would want to do a new EEG, especially if they now want to get a driver's license or renew their driver's license. But if a patient feels fine and their relatives say, no, they don't have any seizures, we would not be sending them to an EEG. But sometimes after we've withdrawn the drug, and if they've had previously a very pathological EEG, been seizure-free with the drug, and a normal EEG, then after withdrawing the drug, yes, we probably would do a new EEG to see if they got back their epileptic activity. All depends on the patient. Everyone is special.
I am now tempted to ask you one question, just for clarity of all the people who are here, that people are asking different questions. In acute symptomatic seizures, sometimes like a head injury with seizures, we start them on antiepileptic drugs, or so many other acute symptomatic varieties of seizures are there, like hyponatremia and so on and so forth. And we have to start antiepileptic drugs. What is the best time to stop in these patients? And that should be a very bold statement that people should take home, because there are a lot of people who continue to have and nobody stops it. Yeah.
What, you mean that the patient comes in with a head injury and they have seizures?
Yes, and he's put on
And
something
then
like
you're given.
phenytoin, which is very common here, and then
Oh,
it's
yeah.
not tapered off, and the patient goes on with it. So, what's the best time to taper in an acute
Well,
symptomatic?
okay. I mean, if you see that they still have a big brain damage, you know, you could see this on the MRI, that they have a lesion there. And they've been seizure-free from the time they came into the hospital. I mean, they were in the hospital, they got phenytoin, and now 2-3 years later, and they're at home, and they're sort of behaving normally, then I think that one could try to withdraw the drug and especially change the drug, because phenytoin is not a drug today that is so advantageous for people. They have the chronic systemic side effects of phenytoin are not advantageous to continue for 20, 30 years, as many people did, with the results of polyneuropathy and all sorts of things. So there are other better drugs. And I think that using phenytoin in the hospital, when they leave the hospital, they should be switched to something else, probably while they're still in the hospital. But maybe that's not an option in India. We always do that in our hospital. We never send people home with phenytoin. It's a very tough drug.
There are a lot of people who are asking, do you believe in withdrawal seizure? You started tapering the medication, looking at
Absolutely.
all the
Oh, yeah.
And what do you then do when you get a single or 1 or 2 quick withdrawal seizures while you're tapering? You've discussed everything with the patient. Do you put him back on the medication? How long do you give it? Do you give some stop gaps like clobazam and then keep on tapering? What is the way?
Yeah, well, I mean, now this is just empirical, and this is what I usually do. If somebody's reducing the drug and they get a seizure, I probably go back to the next level. And then I wait a while, and then we maybe go a little bit slower. So take a longer interval to reduce the drug. I have some patients who have porphyria because of phenytoin, and I'm trying to reduce phenytoin, and this is not easy, you know, and I'm giving levetiracetam on the side as well, and it gets down to a certain point and has a seizure, so I have to go back up the next step, and then we wait a month before we start going down again and maybe increase the levetiracetam. So it's a very tough thing when people get these reoccurrences. When there is no guideline, I think, for something like that. Again, it's individual, and it's just, you have to go slower. With clonazepam, that's a really tough drug to stop. And many in Sweden pediatric neurologists have given clonazepam to patients, and they come, and then we try to get rid of it. And it seems like as soon as I get down to about 1 milligram, then I always get the seizure or the status. And so many patients are just on a low dose of clonazepam because I don't dare to reduce it more. So certain drugs are worse than others. I think that clobazam has been an easy drug to taper down compared to clonazepam, which is really difficult, or primidone and phenobarbital are harder drugs to taper down than something like levetiracetam or lamotrigine. Newer drugs, I think, are a lot easier than some of the older ones. We try to taper valproate a lot because we don't want our patients on valproate if they don't absolutely have to be in it. We try to change the drugs, you know, give something else like levetiracetam, anything, just to get down the valproate. And sometimes it works, and unfortunately, sometimes it does not work. But we see an improvement, a tremendous improvement in their cognition and just their general health if we can lower valproate. At least that's what we find in Sweden. So that's like nobody tries to give it anymore unless they absolutely have to.
Manjari, any comments or questions? I think we have taken most of those 80 questions that came
Yeah.
clubbed into important
Okay,
ones.
okay.
Manjari, you want to say
Yeah.
something?
Yeah, so I think, you know, Elinor, thank you so much for this talk, because this is always a dilemma. And really, there's no one size